Hi, I'm Margaret McIntyre from the Golden Jubilee Hospital in Glasgow. I'm going to present for you today an 85-year-old man who came to me recently with unstable angina. He originally presented back in 2000 and had PCI to his mid-LED with a 2.5mm bare metal stent. He then came back in 2010 and had PCI to his proximal LED and his right coronary artery with 3.5mm drug-eluting stents. He's got diabetes, hypertension, and as I said, is represented now with refractory angina. So he attended for his angiogram. We took pictures of his right coronary artery, which is large, dominant, and unobstructed with very minor plaque disease. And as you see here, this is the iliocranial of the left coronary system. I've got a 6 French EBU 3.5 guiding catheter. You can see there's some modest plaque in the proximal circumflex. This is the old stent up here in the proximal LED, which looks patent, the one from 2010. There's a further stent here you'll see in the mid-vessel. This is a bare metal stent from 2000. There's some new disease between the two stented segments. You can also see there is a tight osteostenosis in this D2 with slow flow, TIMI2 flow. This is the areocranial view, so you can see that proximal LED stent much more clearly here, and it's widely patent. You can see there's this disease beyond, between the two stented segments. You can see this small 2.5mm stent in the mid-LED, which looks to be, in addition to being small, to having some in-stent restenosis. You see the LED further on is significantly larger and healthier. And there's this tight osteal lesion in D2 with the slow flow, and you can see here that D2 comes off the old stented segment, almost appears disconnected. So our strategy here initially was to treat this segment of disease between the proximal and mid stents. And my thinking was that probably because of this old bare metal stent that we should stent to overlap the nice healthy proximal stent and land in this healthy segment beyond the small original bare metal stent. At the start of the case, I felt it was important to try and wire D2 because of this tight osteal lesion. We tried to do this with a Sion wire, a Sion blue wire, and a pilot wire, but were unsuccessful. At this point, being pragmatic, we felt probably that lesion's been there since this original stent was implanted, and hopefully when we pre-dilated we wouldn't compromise the flow. So we pre-dilated the old stent here and this new disease with a 2.75 and then a 3.0 non-compliant balloon. And unfortunately, as you can see in this image here, we lose flow into D2. At this point, the patient developed some chest pain and some ECG changes, so I was keen to recanalize this, particularly to resolve the patient's symptoms. So I decided that I would have to use a more robust wire. I was able to get back into the diagonal branch with a Gaia second wire. What you can see here is me trying to cross into that with a small balloon. This is a 1.0 balloon, and you can see with the middle marker in the balloon, the front edge of the balloon can't cross into D2. Went on to try several other balloons and also several other microcatheters, but was never able to cross into D2. I then took a Caravel catheter, and you'll see here that without much pushing, this slides forward into the vessel without having to work too hard. I was then able to use the Caravel to take the Gaia wire out, which I didn't want to sit in that side branch because obviously it's got quite high penetrative powers and I didn't want a vessel perforation. I was able to exchange that out now for the Sion Blue extra support. So having tracked the Sion Blue extra support into D2, I was then able to deliver a 1.0 balloon pre-dilate, gradually upsized to 2.5 balloon, restoring flow into the diagonal branch. I was then able to track a 3.5 stent covering the original 2.5mm stent in the mid-vessel and overlapping with the nicely patent proximal stent. This was deployed successfully, was post-dilated with a 3.75 and 4.0 non-compliant balloon, and you'll see at the end of the case, even after post-dilatation, across the takeoff of D2, that D2 is widely patent and the new stented segment looks good. You can see clearly here the ostium of the diagonal looks good and we've got TIMI3 flow. So my main comments about this case are that it's often difficult to cross old stents into side branches, particularly with osteal disease, as in this case. I think that the Caravel microcatheter was very useful in this case because it was able to slide with its low profile into the side branch when the other microcatheters were unable to cross. Having delivered the microcatheter, It then allowed me to take out the penetrative Gaia wire, which is dangerous in that type of position, and exchange it out for the safety of the Scion Blue Extra Support, which then also allowed me to track further balloons into the side branch and treat the ostium and restore Timothy flow.